week or two also. All right, we're going to go ahead and get started. This is a pretty quick, I don't think this will take more than 20 or 30 minutes. This is part of what we call the 5 Tips series. Paul Scheer and I did this probably about 10 years ago. And we did just 5 simple tips on different issues and pathologies, and this is a couple of those. My disclosure: I'm the medical director at ProLab Orthotics, and I mean, we're going to talk about orthotics in here, but there's nothing that is going to be specific to ProLab, certainly. Just check one thing here before I get started. All right. All right, so like I said, this is what we call our top 5 tips. We're going to look today at arch pain, and we're going to look at pinch callus, Hallux pinch calluses. So we're going to start here with arch pain. And there's a couple ways to look at this. We're going to be looking at how to treat plantar fasciosis itself with orthotic therapy, and what you want to think about with these prescriptions. Although we have, if you're interested in more detail on prescriptions for plantar fasciosis, I would go to the website, and there's a couple videos there on specifically orthotic prescription writing for this. And we're going to look at then some troubleshooting of patients come back in, they have orthoses, they either have not had complete relief of their symptoms, or they're having some secondary arch issues due to the orthoses themselves. So I think the first thing we need to look at here is our primary goal of orthotic therapy with plantar fasciosis is to decrease tension on the plantar fascia. Big part of this goes back to Cogler's work on decreasing tension using lateral forefoot wedges. And we talked about his study. If you were here for the talk we did on Hallux limitus a week or two ago, we talked about this study there also. But he did some really interesting work using cadaver legs. He would put them in a unit that would load them. And then in this study, he put wedges under the forefoot and the rear foot, medial wedges under the rear foot, medial wedges under the rear foot, and lateral wedges under the rear foot, and then the same on the forefoot, and then he combined them. And essentially what he found is that adding valgus wedges, forefoot wedges, decreased tension on the plantar fascia, while medial forefoot wedges increased tension on the fascia. So one of the first things we want to think about is when we're writing these prescriptions, even when we're taking the cast, is how do we try and enhance a valgus force on the forefoot in order to decrease tension on the plantar fascia? Well, number one is that we can evert that forefoot while we are taking the cast of the foot. So this is tip 1 of our 5. We can also add a forefoot valgus extension. So here we're everting the forefoot by casting that first ray plantarflexed. And this is true whether you're using plaster or a scanner, but all I've done here is taken this foot, I put it in standard neutral casting position, but on this right-hand picture here, I've taken my finger and just gently plantar flexed the first ray to the end of its range of motion. Apparently I have a timer on my slides. I did not know that, but and you can see how we've brought that first ray down, and that increases the valgus position of the forefoot. You can do that a couple of different ways. Here we're plantar flexing the first ray and dorsiflexing the hallux. Here's Paul Scheer just gently dorsiflexing the hallux. Also, you can add a forefoot valgus extension. Okay, this extension compared to a reverse Morton's is the same thickness from 2nd to 5th. This is going to be thicker under the 5th and then be beveled down to essentially nothing under the 2nd. And certainly do a combination of those. Tip number 2 is to try and have that orthosis conform closer to the arch of the foot. And this was another study by Cogler, again, loading the cadaver leg up and then putting different shaped orthoses, different arch height orthoses under there. And this is a quote from his 1996 paper, that the orthoses which decrease plantar aponeurosis strain had closer surface contours of their medial and central regions, and the angles related to their arch shape was more acute. That's a lot of words to say it conformed closer to the arch of the foot, such as this one. And you can imagine if that device is gapping from the arch, then the foot has more potential to flatten to reach the orthosis. And as it flattens, it lengthens. And as it lengthens, you're putting more tension on the plantar fascia. So if you prescribed let's say an orthosis with a minimum fill, then when that comes back, you're going to, and we'll talk about that in a second here, you're going to make sure that it does conform the way you want when you put that patient back in that casting position. So again, how do you get closer, get the orthosis conform closer to the arch? Well, one is when you prescribe you're going to prescribe a more minimum cast fill. Here we have 3 old-fashioned plaster cast, but you see the white is what the labs added, the blue is the original foot. This one in the farther back here, further away from you, has more blue, which means there's a minimal amount of plaster cast added to the medial arch. So a minimum fill is going to usually conform closer to the arch of the foot. You can also, you want to make sure your lab's not overfilling. I mean, this is actually a big problem. Orthoses that come back and where they gap significantly from the arch because the arch has been overfilled. The reason for this is you go with a more minimum fill, there's also more potential the patient may complain of some arch irritation. It's a higher arched orthosis and may more likely require some modification. Easy modification, which we'll talk about in a second, but if you overfill the arch, then there's less potential of that occurring. So you really want to keep a close eye on making sure that your lab is doing what you're requesting. You can also increase the arch height by simply inverting the positive cast. So you can see that this is thicker under the first than under the fifth. And as we invert that positive, that arch has to drop farther to the ground, and we have a higher arch. So very commonly for a patient with plantar fasciitis, if I want a really close contour, I may ask for a minimum fill with a couple degrees of inversion. But keep in mind, this is going to differ from lab to lab. We tend to be really close to the contour of the arch, and other labs may put a little more fill in. It doesn't mean you can't accomplish the same thing with another lab. You just may need to invert it a bit more to do so. So a minimum fill with 2 degrees of inversion from lab A may be different arch height than a minimum fill with a 2 degrees of inversion from lab B. So just become familiar with what your lab is doing so you can make those accommodations, and you have a pretty good idea with any combination of fill plus inversion, how closely that is likely to conform to the arch of the foot. And talk to your lab too. You can ask them, if it's a minimum fill, how much plaster are you adding? If it's a maximum fill, how much plaster are you adding? You should be able to get a good idea. Now, if that orthosis, we're still on that conform close to arch tip, if that device comes in, let's say you made it or someone else made it, and it's just not conforming very well to the arch of the foot, you can increase the arch height. This is what I use, is a little pour-on arch pad like this, and if it has a cover on it, I'll try and work that cover up a little bit and just slide that arch pad under the cover. And then we have a closer contour. You can also do a first met or a first ray cutout to let that first ray plantarflex take some tension off the metatarsal. Now, if you've done we talked about this on that Hallux limitus lecture too. If you have plantarflexed the first ray and your lab hasn't overfilled the cast, or you haven't prescribed an overfilled cast on the orthotic, then you probably don't need to do this. But if the orthosis is gapping and you want to let that first ray plantar flex a bit more, take some tension off the fascia, this is certainly a way to do so. Okay, tip number 3 on arch irritation, or tip number 3 on arch pain in general, is adjust for arch irritation. So this is the patient that comes back. You did prescribe that orthosis. Maybe you got quite aggressive with the arch and it's conforming really nice to the arch of the foot, but it's causing some pain. And let's look at some easy ways to adjust for that. Here, let's just say this patient was having pain here kind of just in front of the calcaneal inclination. And we mark on the bottom of the orthotic where that is, and then just take that up to a grinder and thin it very locally. Just you're trying to make the device more flexible right in the area where it's bothering the patient. And doesn't take much. You'll be really, if you don't already do this, you'd be very surprised how little you need to take, how little plastic, how little polypropylene you need to grind, and how little you need to increase the flex to make a real difference on the orthotic reactive force that's being applied to the foot in that region, in order to, and how much that will improve their comfort. So we titrate this. What I'll do is I'll just write on the, I'll put a mark, pen mark, a Sharpie mark, or a pencil mark on the orthosis, have my staff grind off that mark only, and then let the patient try it. And if it's better but not quite enough, we'll do a little bit more. And so you can really localize where you're adjusting that device, and fine tune it for that patient. I would actually find it very hard to practice the orthotic therapy the way I do if I didn't have the ability to make these adjustments in the office. Tip number 4 is accommodate a prominent plantar fascia. Certainly a common reason for arch pain is the fascia is too prominent and it gets irritated. That also, if you have a prominent fascia, then the orthosis itself can apply force to the fascia and increase tension on that fascia too. So you can prescribe, a couple ways to handle this. You can prescribe a plantar fascia groove to be added into the orthosis, or you can add one after the fact. So here in this one, we see that fascia groove prescribed in it. And then here's a patient that came in that had a prominent fascia, but the orthosis did not have an accommodation. So what we did is we just put a layer of Poron down, beveled it on either end. And then I marked the prominent fascia with some lipstick and held the orthosis up there, got that mark on it, and then used, I used this, this is called a Ticro cone. It's a polypropylene polisher. And I used the Ticro cone to grind it in, but you could even use, I mean, there's tips of a Dremel you could use to put that in there. And then we just put so there's our plantar fascial groove, and then we put a cover on it and we're done. The way I do it more often now, is so when I prescribe a cover, if I'm unclear if I want to add a fascial groove, but I think I might need to later, I'll prescribe a 2-layer top cover, usually EVA on the top, 3 millimeter, and then a 1.5 layer of Poron glued to the bottom of that top cover. And then if I need a groove, I'll grind it directly into that top cover using the same technique I just showed. And then we have 1/16 inch, 1.5 millimeter EVA in the office, which is super thin and super easy to apply. And it conforms to curvatures really nicely. And we'll put that over the top of that original top cover. We found that to be a little bit easier way to add that groove after the fact. Tip 5 on avoiding arch pain is just to avoid supinating your negative cast. And this is a supinated cast here, a much more acute arch than on a neutral or a pronated cast. So just avoid supinating that negative cast. This is why I think it's really critical, if at all possible, that the doctor takes the image of the foot, unless you have extremely well-trained staff, or at least the doctor is evaluating that image on every patient. Also, another reason I'm a big fan of 3-dimensional scanners is it takes so little time to get that image that you end up, we tend to see these are better images overall than casts, simply because I think the doctors are doing more of it because it's so quick to get it done. The solution to this problem is tough. I mean, if we get if we get a cast in that's inverted, it's really hard, or that's over supinated, it's really hard to make a good orthotic off of that. We would hope that we can just ask to have that redone. But certainly, if you do have casts if you do have staff that are taking your images or your casts, then have them review exactly what to do. We have a really good video on the website that Paul Scheer did many years ago on casting technique. And even if you're using a scanner, the positioning is still exactly the same. Again, I think the doctor taking the caster image or extremely well-trained staff And I think that every image should be evaluated by the doctor. And we don't need to go over that right now. That's all available on the website, but here's a list of what we want to look for on a good negative cast. Okay, so that is 5 tips on plantar, on arch pain. And now we're going to do 5 tips on preventing or treating hallux pinch calluses, mostly on prevention. So obviously callus, just a hyperkeratotic lesion. And we want to keep in mind that keratoses are not just pressure, they're friction. A lot of the evidence on diabetic ulcerations, which usually begin as a keratosis, is showing that it's, although we've been treating them primarily as a pressure issue, friction plays a big role, and friction should be addressed when we're trying to treat both calluses and ulcerations. So the hallux pinch callus obviously is the medial hallux, sequela of functional hallux limitis, in that you're not seeing full range of motion at the first MPJ during toe off, and the patient ends up abducting the foot and rolling off the medial hallux, pinching this skin here and forming that callus. So our goals is to try and treat that functional hallux limitis, is to enhance first MPJ dorsiflexion, and then second is reduce local hallux friction. So our first tip for preventing hallux pinch calluses is, again, cast the first ray plantar flexed, as we just talked about. Our goal here is to get a device that reduces functional hallux limitis. And this is what we talked about, I think it was last week on this webinar. And that webinar is available on the website if you want to see it. But I did talk about this study in there that when orthoses were used in stance, hallux dorsiflexion increased about 90%, and that when they're used in gait, subhallux pressure reduced by about 15%. Subhallux pressure is will reduce if you have normal motion at the first MPJ. Again, close contour to the arch mainly to let that first ray plantar flex. You can see that with this higher arch on the orthosis, the first ray is allowed to plantar flex. We don't need to go over again how to accomplish that. Tip 3 is use a reverse Morton's extension. Let that first ray plantar flex. A study by Rukas in '96 showed that position the first ray, when you used the reverse Morton's, that you increased motion at the first MPJ. And the opposite true is when you used a Morton's extension, you decreased it. And again, we go over this talk in detail in last week, or that study in detail in last week's lecture on hallux limitis. And then reduce rear foot eversion. The rear foot is everting, or you have a high supination resistance. It's going to be much harder for the windlass mechanism to function. In this study by Harridan and Bevan, they used several wedges under the medial forefoot, and they found that the greater the amount of wedging, the easier it was to dorsiflex the hallux. Now you can think about the design features that you want to reduce supination resistance, reduce heel eversion. Might be a deep heel cup, a wider width, medial heel skive, you do a Blake inverted, there's all, whatever varus wedge technique you want to put more surface area medial to the subtalar joint axis. If you're not familiar with supination resistance, I would go back to the talk we did, I think 2 or 3 weeks ago, on how orthoses function and critical clinical evaluations. That's also on the website. And then tip 5 is to decrease hallux friction using a polytetrafluoroethylene, PTFE patch. That is this little patch you see here. This is really interesting stuff. This was developed primarily for treatment of diabetic ulcerations. It has the lowest coefficient of friction of any material you have available to put onto an orthotic device. And essentially, I think what we want to do to best treat this is to combine an orthosis that treats functional hallux limitis with PTFE to decrease hallux friction. Here's the coefficient of friction of PTFE comparing to all the polyethylene foams such as EVA, to moleskin, to these are the plastics like polypropylene. Here's leather calf skin over here, leather, whatever russet leather is on there. But PTFE has a much, much lower coefficient of friction. And even more interesting is when it gets wet, the coefficient of friction does not change. And that is untrue of any other top cover we might use on an orthosis. So all these other materials do have a higher coefficient of friction when they get wet. They do get wet inside a shoe. So again, this material is pretty amazing in its ability to decrease friction in that way. And what you just simply do is you take this pad and you apply it to the orthosis right where that callus is or where that ulcer is. It comes either in this shape for the first, this covers the hallux, the first met head, and the second met head. It also comes in ovals where you can apply it just in those local areas where you need it. It just peel and stick. The stuff lasts for about, I would say the average person about 6 months. Over time, you'll start to see some little cracks, white lines in it, and you just replace it. I just tell the patient, heat up with a hairdryer, peel it off, and put on another one. You can order your orthosis with the PTFE on it. You can ask for it to be added, to be sent along as a separate piece. You can even buy the stuff on Amazon. It's under the brand name Engo, E-N-G-O. And so anyway, I think it's a really, anytime you train a callus, I think you should be thinking about doing something with PTFE also. Anyway, summary here, like I said, it's pretty short and sweet today. Appropriate orthosis prescriptions can help effectively treat many common causes of arch pain. And hallux pinch calluses. I don't know why I didn't put that in. But also, we need to be able to effectively troubleshoot these issues. And I think it's really critical that if you're going to do highest level orthotic therapy, you need to be able to adjust the orthosis. I think it's hard to do very sophisticated orthotic therapy without the ability to without having a grinder, at least, and some glue in your office. So that is all I have today. If anybody has any questions, go ahead and put it into the chat. And also, like I said, I'm going to take a look and see what timing people like. Let's see. Time, Florida, the people love the time because it's 5 o'clock. Central time zone, evening, early evening. All right, so the 3 people that said something would rather have it somewhat later. So I think we may start doing that. I think people are going to start going back to work a bit here. All right, somebody had a question on the Blake inverted technique. And I don't know if I can find a good picture of it, but here's what it is. So first of all, there's an excellent lecture, or not lecture, but interview with Richard Blake about how he developed the Blake inverted technique on PodChat Live. And maybe it was 2 weeks ago, I did a talk on the best online resources on orthotic therapy. One of those is a podcast called PodChat Live, P-O-D-C-H-A-T. And they did a interview. It's exceptional. It's Craig Payne in Australia and Ian Griffiths in the UK, interviewing podiatrists and biomechanists and researchers around the world on all kinds of things having to do with mostly with sports medicine and foot mechanics, but on other topics also. And they interviewed Rich Blake a few weeks ago. So it was a really, really good interview on how he came up with the Blake inverted technique. But essentially, it is a varus wedge technique. And what he does, or what the Blake inverted technique is you take your positive cast. Let me go back to that picture of a positive cast, because this probably was nearly a Blake type of inversion on this positive cast here. There it is. And it is inverted anywhere from 10 up to 50, 60 degrees. Rich said the highest he's ever gone was 70 degrees. Now you can imagine if we invert this thing 50 degrees, it's going to be up to here, and that arch is going to be gigantic. No person in the world will tolerate that arch. So the next part of doing that is you fill the arch back in. And by filling the arch back in, you bring it down to where it was before. So now you have this inverted cast, but the arch is essentially the same height as it was in the negative cast. But by doing so, you create, if you did a cross section of the orthoses made off that cast, it will have a varus wedge in the heel cup. So what you're doing is you're not trying to take that foot necessarily and invert it 25 degrees. And what you're trying to do is you're trying to create that varus wedge, which puts more force medial to the subtalar joint axis. Now, I used to use a fair number of Blake inverteds when I first started practice, but then Kevin Kirby came along with the medial heel skive technique, which essentially gives us much of the same benefit as the Blake inverted technique, but much, much easier cast work, much less expensive, much less involved, much easier to replicate. I mean, the cast work for a Blake inverted really takes a skilled technician, I think. And so I haven't used a Blake inverted in probably 20 years, but he set the precedent for how we use varus wedging within orthoses now. So again, I don't think it's a device you may not be using it very much, but it was certainly the grandfather of the medial heel skive technique and other techniques to increase varus wedge effect in order to transfer more force medial to the subtalar joint axis. So, and if you just go online to, Rich has a blog, I think it's called Dr. Blake's blog, or you'll just Google Rich Blake blog and it'll come up. He gives some good video descriptions in there of the Blake technique. All right, anything else, guys? All right. And the UK wants it earlier. I will tell you, whatever we do, these will be recorded. Yeah, and I don't necessarily need to hear you snore, but you're still welcome. All right. That's all I got. All right, everybody. Have a great day. Anna, have a great night. And we'll let you know soon what we'll be doing next week or the week after.